the display, the
Yeah,
past, the present, and the
the
future.
Berlin Ambrosio display the past and the future. Because of the bad, the bad software or the bad screening analysis is now 10 years old, right?
Yes, yes, absolutely.
So I think you have another baby now.
Yes,
Okay.
you know, uh, all the concept of the tomography is to go beyond but not over. So we have to acknowledge two things. First, the source of the information and the type of information. So we have topography, front surface curvature, we have tomography, three-dimension data, and now we have biomechanical data along with that, which is the cornea deformation from the corvus. We studied that before the corvus with the ocular response analyzer from Reichert, which is a very good instrument, allows you to understand the cornea and the eye in a different way, but it was limited to the front single reflex. Now we have the Scheimpflug image deformation, and not only that, we have the same company doing both instruments, so that the ability to combine the data is much reliable, and it's something we have done already. When we were working with tomography and biomechanics with different instruments, different companies, the integration software was never possible. So the Corvus and Pentacam, they do work together. But going back to the tomography data, because I think it's very important that we understand that we can do better with tomography because of the artificial intelligence. So we have the BED-D, the first version, the second version, which is the one that we have now, and that data is getting better processed with the Pentacam Random Forest Index. I can send you the papers in the AJO from my colleague Bernardo Lopes, who did a beautiful thesis on artificial intelligence to improve, to enhance ectasia detection. So we included patients with pre-op data from Pentacam on cases that develop ectasia, and also a larger series of unilateral ectasia or asymmetric presentation, better saying, not unilateral. The best terminology is very asymmetric ectasia. So the future of the bed display is to integrate both eyes and also integrate Pentacam Random Forest Index and other possible improved artificial intelligence index that we can develop. And eventually, I'm not sure how Oculus is going to display that on the software. And that will be combined with the enhanced ectasia susceptibility score, which combines the data. I can show you a few slides if you allow me to share my screen. I will share you some of these slides. I was preparing my talk for
Tomorrow?
For tomorrow, yes. We have our colleague Muhammad Shafiq also participating with that.
I was with Professor Shafiq 15 minutes ago. Was
great.
was an online meeting, and
Yeah,
announced about your tomorrow meeting. Yeah.
All day. Yeah. So this is the from pre-op ectasia, 105 eyes. You see the BED-D is much better than the IS value, but the PRFI is even better. But when we combine that data with the enhanced ectasia susceptibility score, and we improve with the concept of relational tissue alter, which is the flap and ablation, and age is very important, you improve the algorithm. And if you consider both eyes, all these cases here, the fellow eyes are here. So we can tell you it's 100% sensitive in this series. But age came as an important parameter because age is related to biomechanical properties. That's why cornea properties are important. So did I answer your question to the bed display? The future is really hard to understand what's going to be the real future of the display, but the future of the understanding is multimodal idea. We go to the multimodality, which is understanding the cornea and the eye in a better way. We have segmental tomography with epithelial thickness. We have whole eye wavefront data, and eventually some cellular data that we can come with confocal microscopy may improve the detection of ectasia. And not only detection, is diagnosing, prognosing, follow-up, planning the treatment, all these aspects of the understanding of the applications of
Yeah.
the diagnostic imaging.
Yeah.
Yeah. Yeah.
Dr. Ambrosio, may I ask something? Or
Sure, please.
yeah. As far as I understand now, you are combining three models of imaging: tomography, and biomechanical module. Are you going to combine all of them in one single mathematic module or something? Or
That's the idea. That's the idea.
that's the idea. Yeah.
I can announce you that Oculus Works now has a very good advanced working on the epithelial thickness module with OCT. So in the future, and we already have a Pentacam wave. It has AXL and N wave, and the wavefront data may help us a little bit, but I am much more confident with the integration of epithelial thickness. So we may have epithelial thickness on the integration data, but I don't know when it's going to happen. And
Yeah.
We have seen the first prototype, and it's very promising, but you know, we don't know now. It was hard to predict when a few months ago, and now it's even much more complicated, but hopefully soon.
Yeah, the idea is extremely excellent because you are studying the cornea in different ways. So you are assessing the different aspects of refractive surgery and its impacts. If you not only the thickness or the topography, but you will include the mechanical properties as well in the assessment. And from this module, you can predict. The next step will be the prediction of which cases are susceptible, which cases are going to get ectasia or something like this later on. But I think this will be excellent. Sure.
One major step forward that we've done is to understand that we are not looking for keratoconus. We are trying to detect susceptible cases for progression. That's when we do refractive surgery. And when we see a patient with keratoconus, we have to understand when we should intervene, because if you miss the opportunity, it may be losing an opportunity to get the patient to do a less invasive procedure. In another way of thinking, if you do it too soon, you may harm the patient with a side effect or a possible complication if the vision is still very good. So it's very important that you understand when and how to treat patients with keratoconus. And keratoconus and refractive surgery, they are very different. Besides being alike, they are different.
Yes, sir. To summarize, the newly added points to the previous bed is the consideration for what's newly understood about the corneal biomechanics, and the added points about the epithelial mapping and the studying of the corneal epithelium.
For now, we have the tomography and biomechanical integration.
Yes.
For the near future, we will have axial length and wavefront data of the eye integrated. That's something that we may have it next year. And in a little longer future, hopefully very soon, or not too far, is the epithelial thickness coming. But I see other companies trying to do things like that. The CSO MS39 has a good epithelial thickness module. Anterion from Heidelberg also has done some promising work on the OCT, anterior segment OCT. And we have Riloan spectrometry coming always as a promising thing that can come at any time. Maybe other technologies for biomechanical assessment with corneal vibration doing with OCT. There are some interesting work on that. So the future is very promising, you know. But what we have today it's corneal tomography with the Scheinflug imaging and biomechanical data with Scheinflug imaging. That's what we have. today, 2020.
Yeah,
In,
okay.
two,
Which is combined in the TBI.
yes, the TBI is definitely the best way of doing things.
Yeah, trying to increase the sensitivity for detection of early cases of keratoconus.
Yes.
Yeah, always going to the surface, not to the bottom of the cornea.
Well,
Okay,
you know,
the second question. I can go for the second question.
yes, the second question is about smile and biomechanics, right?
Yeah. Perfect.
Okay. You wanna ask, please?
Yeah.
So the question is biomechanical properties change after smile if this is less than LASIK. And I think it is. I think smile weakens the cornea less than LASIK, but more than PRK. That's the statement I have. I
More
don't
So
think,
it is a midway between.
yeah.
absolutely, it's in midway. And if you go for a very thin flap LASIK, I would say
It looks like
probably,
a modest answer now.
actually, that's always my feeling. You know, I never felt that
But,
smile would weaken less than PRK. I never felt that.
but
But I know
don't you
that,
think? Sorry,
yes,
don't you think that whatever you did with LASIK, or as long as you interrupt the anterior corneal stroma with SMILE or LASIK, you are compromising the architectural changes in the cornea, so it has the same effect.
absolutely. I want to share you one very important slide that I use all the time.
Yeah.
This is the slide. I used that slide in the presentation the other day, and you know, this is the slide. You know, the similarity between keratoconus surgery and refractive surgery is huge, but this is not the same. And if you see the DNA of a lion and a small cat, it's about the same metaphor. You know, the lion, if you try to pet the lion as you do with a cat, you will be in big trouble. So if you try to do refractive surgery in a patient with keratoconus, is like trying to pet a lion. Of course, you can domesticate the lion, and you can do that, but you have to understand that is different. Having said that, going back to the idea of PRK and SMILE, a lot of people are doing PRK in refractive as a refractive procedure for keratoconus for a long time. If they obey the what I say Gustavo Tamayo's rules, which is not doing in a very thin cornea, in a patient that's too advanced, in a patient that has correctable vision. So you may have good results with surface ablation, and eventually, some cases may even tolerate SMILE, but you go into an area of risk that you have to understand, and most importantly, you have to educate the patient about it. So I have patients that come back 2 years after surgery asking, do I need to do cross-linking? Because I educated them to understand the risk of needing a cross-linking if they have some progression. However, I have to say that I had my first case of ectasia in a SMILE case for high myopia. That was with a very normal topography. And I could see retrospectively the TBI in that case was abnormal. But in 2014, when I did the surgery, I had the measurements done, but I didn't have the TBI at that time. So SMILE weakens the cornea much more than PRK in my understanding. However, what weakens the cornea more than any refractive procedure is eye rubbing. So tell the patient not to rub the eye is probably a message that is very simple and very efficacious for avoiding ectasia to progress.
And you told me, sir, that you have noticed the changes in the back of the cornea on the first visit, but after time around 2 years, you found a marked change in the posterior elevation of that patient in comparison to the preoperative one. So you told me as a notice in the last meeting that we have to consider the changes even even not a very marked changes in the back of the cornea on doing follow-up for the patients after LASIK, right?
Yeah, this is something we have to take the time to look at these maps,
Yeah.
and especially in higher correction cases. But you know, we had a very good talk the other day about ICLs, and ICLs are, you know, the phakic IOLs.
Yeah,
There
yesterday.
are other phakic IOLs on the market, not only the ICL, but you know, this may be a good thing to consider in some of these cases as well.
Okay, but nowadays, according to my school, I'm shifting in high errors to the phakic IOLs and no more correct a lot of degrees, myopic -8, -9. I'm shifting now to the phakic IOLs instead of the corneal laser ablation because of
That's
the
why,
matter of the weakness or the biomechanical changes.
yeah, that's very fine.
Okay.
Of
So,
course, phakic IOLs have other types of complications as well, but you know, you have to understand what's safer is. There is nothing that is 100% warranty that's going to be perfect.
yeah,
So you have to
if you
understand
ask
the compromise.
if you ask yourself about the risk for the patient, I think you have to change the mind to the phakic IOLs. Even they carry some complications, but still preserving the cornea.
Yeah. Yes, absolutely.
Yeah, because of ergotictegia, we cannot deal with it. You know, sir, that the behavior of the corneal, the post-LASIK ptegia is much different than
Yeah.
primary keratoconus.
We have some cases with phakic IOLs, 5 years, that have endothelial cell loss, and they have big cells, like 700, 800 cells per millimeter square, big cells,
Yeah,
and still they have 20/20 uncorrected.
yeah,
Tell this patient to take this lens out. It's a nightmare.
yeah,
So there are different issues. It's not only endophthalmitis in the first days after surgery.
yeah.
Definitely. Long-term complications also can happen with phakic IOLs. So there is nothing 100% warranty. That's why I do believe if you're going to do phakic IOLs, we need to have the best planning as possible. And that's why I believe we should have high frequency ultrasound to see behind the iris if you're doing posterior chamber IOLs.
Yeah. Okay. So to summarize the answer of this long question, Ambrosio said, if you ask yourself to do or not to do, you haven't to do. You have to shift your mind. The first point. The second point, if you notice any changes in the posterior elevation of the patient after surgery, you have to follow this patient closely and suspect this patient until proved otherwise. The third
Tell the
point,
patient not to rub the eye. Very important.
yeah,
Maybe that may be enough to stop ectasia progression. Riboflavin orally maybe help.
riboflavin orally with the
Yeah, oral
sunlight.
riboflavin.
Yeah,
Yes, and you have a lot of sun in Egypt, I'm sure, and like in
yeah,
Rio, we
yeah,
have it for free. Oxygen and sunlight is for free. They're still for free. Sometimes it's hard to get it at home, but you can still have some, even at home.
yeah, yeah.
But
Okay.
so,
Fortunately, we have the sun. Yes.
yes,
The third point, if you find any changes in the epithelial count in a patient with a phakic IL, you have to advise or to remove this phakic IL.
yes.
Yeah, before going to corneal decompensation later, right?
Yes, but sometimes it's hard to make a decision because you
Yes.
see a patient with a low endothelial cell count. Even in the best hands, you're going to lose some cells when you do the explantation.
E- e-
And
Even the difficulty for the doctor and the
yes,
patient, even the difficulty, we have to know the right rules, and then we can do it individually for the different patients and different situations.
yeah, I have a patient that she's under this situation. She's married to a physician who I did LASIK, and she had a phakic IOL, anterior chamber phakic IOL, the one from Alcon, the one that Alcon took out for the market. If I look back at her case, she should never had that lens implanted because of the AC. but she had it, and she was a -9, and she was very happy for many, many years. And she's still seeing well, but she has a low endothelial cell count, and she decided not to take it away, just to let the cornea to decompensate and then do a DMAC, possibly with a cataract surgery in the second step. So that's a decision. And I started her on Ripazodil for trying to improve her cells, and she's doing well. But you know, I don't know until when. It's an issue.
Yes, sir. Thank you, Dr. Ambrosio, for this good question. For the second question, and before going to the third one, let me to welcome Dr. Yasser Rifai from Morocco. Hello, Dr. Yasser.
Hello.
Dr. Yasser
How are
Rifai,
you?
one of the eminent refractive surgeons, and he gave us a very good, wonderful presentation about epithelial mapping and detection of the early keratoconus. Yeah. We were talking about that with Professor Ambrosio now.
I wanted to listen to that talk. It was in the winter
ophthalmology
meeting.
web meeting, on the ophthalmology web meeting. I invited you many times to present on this meeting, but I know that you are busy.
I will present.
But you have to. But you have to really.
It's a virtual meeting.
Dr. Yasser, answer him.
Yes, yes. The internet is I have very low speed internet.
Okay.
I don't hear.
Okay. Dr. Ambrosio, it's a web meeting. It's a web meeting for online presentation as a watch party. Then it's replied on request, upon request after that. Okay. But please, sir, when you get a good time and a free time, you have to share, please, for this web meeting group. Actually, the group, the ophthalmology web meeting group now around 2,000 members, and they are waiting for your presentation.
Let's schedule that during next week. We can do that next week. I'll be happy to do that next week. You know. Okay. The president is starting, and I really want to see what's going to happen, because we need to plan for the next weeks. So
yeah.
Okay.
Good luck with that.
we can go over on the coming questions. If we have another 10 minutes, can we have another 10 minutes?
Just me.
Yeah. Okay. Third question. Thin flap is always keeping less corneal power reduction. Is it true?
Yes. Thin flap is much safer. It's much safer. You need a good keratome or femtosecond laser for that. Yeah. Otherwise, you may risk to have a buttonhole or other problems. But thin flap is safer. It's less dry eye and less ectasia.
So we can conclude. If
less dry eye, you say, Dr. Ambrosio?
Yes, we did a study a while ago, more than 10 years ago, about correlating flap thickness and the nerves that you cut, and also the need for dry eye treatment with cyclosporine, topical cyclosporine. It was published in the JCRS. You see, my colleague Marcela Salomon was the first author with Steve Wilson and myself. Femtosecond laser, thinner flaps were related to less severe dry eye after LASIK.
Please, I have a question. I don't know if you hear me.
Yeah, okay, yes. we are hearing you.
What you call thin flap? It is 100 or less or more?
I would say 110 is already thin. Okay. I don't like to go less than 90. The sweet spot is between 120 and 90, and 120 is good enough. And also 120 is the angle that I use for the edge. I invert the cut for 120 for every case as well.
Actually, we have Moria X90, which is almost giving 100, 110 or 120.
SBK, the little blue one. I love that one, the blue
SBK,
one.
Yeah, SBK, but it's not commonly used in Egypt. But actually, when I go to the femtosecond laser, I would go for 90 micrometer flap, 90 micron flap. Yeah. Yeah, I'm always doing the femto flap as 90, just 90, to get the benefit and the advantage of the femto laser in thinning in the precise thin flap. Okay, very good question, Dr. Yasser. The fourth question is, what could be a factor for post-LASIK ectasia after hyperopic correction? The ablation is mid-peripheral, not central. What could be the factor in your opinion?
I have seen a few cases of a very thick flap in hyperopic ectasia, hyperopic LASIK ectasia, and all these cases had a thick flap. And of course, and you know, what is thick, I think there are some cases that are very thick. The keratome made a bad cut, a very thick cut.
160 or more.
Yeah, maybe even more. One of the cases, the cut is like a lamellar cut. You can see even at slit lamp. And the patient had an ectasia after hyperopic LASIK in one eye.
Yeah.
The other
So
eye,
in case,
sorry?
So in cases of hyperopia, if this is true, femto flaps is better for that.
Oh yeah, femtoflaps is better for everyone. But you know, the cases I've seen with ectasia after hyperopic LASIK,
the question.
they were related to thicker flap.
Thicker flap with much reduction of the corneal power. Yeah.
Yes.
Not related to the ablation itself.
You know, the ablation is in the mid periphery, and eventually it's not going to be the issue for biomechanical decompensation. However, it's something, you know, I have seen hyperopic keratoconus. So you may have a weak cornea with a mild keratoconus, a foam fruit, and have hyperopic LASIK, and then it's going to decompensate.
Even from the cut itself.
Okay.
But the commonly asked question in that in hyperopia, in hyperopic correction, the regression, about the regression hyperopic correction.
It's a different story, you know. Hyperopic regression is epithelial filling of the ablation position, and it's not related to ectasia at all.
How can you minimize it?
Larger ablation zone, and look at the epithelium before surgery, so that you make sure the epithelium, the minimum thickness is more than 40 microns, 40, and this will be an indication that you have a good epithelium for steepening that cornea.
The commonly
used. You recommend serial mapping in the hyperopic refractive surgery is better. Sure.
Yes, you know, hyperopic refractive surgery, you need epithelial mapping.
Okay, actually, sir, the commonly used question, but I missed it. The ongoing steepening of the center of the cornea after ablation, after the hyperopic correction. This is what I mean. The hyperopic correction may steep the center of the cornea above 50. Is it considered as a keratoconus?
No.
Okay,
no.
It's not a matter of weakness in that.
No.
Just for the aberration, the quality of it.
Yes. No, I think it's not a keratoconus, and it's very important that you differentiate, because if you have an ectasia after laser vision correction, you need to do the Atkins protocol. If you have a hyperopic ablation that is decentered, that is irregular, you can do just surface ablation, just custom surface ablation, then you'll be able to treat the patient. Of course, you need to plan that accordingly, and again, epithelial thickness is a very important tool for having this. You know, I have to excuse myself. And I really enjoy talking to you guys. You have excellent questions and makes my mind really think with a very good, good ideas. But let's plan to do a talk about that, and I'll prepare a talk with all these answers for you. And let's do that next week. We can do that even if the weekend or Monday, you know, anytime. We are on quarantine, and we should.
As long as we are impacted with Corona, so we have more time to spend with.
Absolutely.
Yeah, I feel that you are comfortable in for the time and for the other deeds you are going to. So I will say thank you very much, Dr. Renato,
Thank you.
for this
Keep all of you
good
keep
time
safe.
and
God
good.
bless God bless you and your families. Thank you very much for the attention. We talk soon.
Okay, we'll arrange with you for the coming meeting. Okay, thank you very much.
Bye
Yeah,
bye.
you can go now. Bye bye, sir. Bye bye.
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 Thank you very much.
Guys, we are still here if you want to complete.